Hey everyone, thank you for taking the time to watch this PowerPoint that Laura and I put together as unit-based education for our new activity Apron initiative. The goal for our project is to hopefully decrease the use of physical nonviolent restraints and chemical antipsychotic adjuncts on our unit in confused patients. With your effort and teamwork, we really hope to make an impact on the restraint use in our patients and to improve patient outcomes, decrease length of stay in the hospital, and overall just experience less agitation. The use of physical and chemical restraints such as vest, wrist, and mitt restraints as a nonviolent option for restraints in patients who may be pulling at medical equipment, along with antipsychotic adjuncts, have shown to increase length of hospital stay and cause other complications in patients, especially experiencing dementia or delirium, such as worsening agitation. Per JACO, before we even put restraints on, all other alternative measures must be taken to ensure that the patient was really given the opportunity to demonstrate capability to safely remain unstrained while we treat them in the hospital. So these aprons really will serve as another alternative for another alternative intervention to restraints prior to us applying them. Previous studies have actually shown a positive impact in the decreasing of application of restraints in delirious patients with use of activity aprons such as these. The activity aprons really offer an alternative stimulation rather than tugging at medical devices and trying to get up inappropriately. So it has shown to be successful in other studies that have been conducted. So since January 2021, we have had 22 patients on our unit placed in nonviolent physical restraints. In most cases, these patients are experiencing delirium, they are experiencing increased stress, they are experiencing TBI and AWS symptoms, and in most cases, antipsychotic medications have been used as adjuncts to the nonviolent restraints. This is kind of problematic because antipsychotics really have been shown to increase mortality risk in patients with dementia. Many of our patients who've been placed in restraints since the beginning of the year do have a past medical history of dementia, and antipsychotics also show very little improvement in patients who are already suffering from delirium. So not only does it not really benefit them to give them antipsychotics, it can also lead to unnecessary complications such as prolonged QTC, hypersomnia, and increased confusion. If you look at this graph over here, this is kind of an outdated graph just because we haven't been really doing audits since the beginning of COVID, but you can take a look over here and see this dotted line over here is the NDNQI benchmark for restrained patients, and these are our rates over here. You can see that these last two ratings that we have, which really are kind of outdated since January 2020, they are above our benchmark, the NDNQI benchmark. In order for us to be magnet redesignated, we have to have 3 ratings below the NDNQI benchmark. So you can see here with these patterns, most recent patterns that we have, that we have been above the benchmark, and we could use a little bit of work. We're also hoping that the use of these activity aprons will offer stimulation to patients, keep them from, trying to move around more than they should, such as trying to leap up and out of bed. These two charts over here, again, not super duper updated just because of the audits that we've been lacking in. You can see over here that we are well above the NDNQI benchmarks. As you can see, this is our NDNQI benchmark over here, and these are our fall rates in the past dates. You can read the dates over here. The graph to the left is actually falls that resulted in harm to the patient, and these are just our falls in general. Laura and I actually did collect extra data, and since the beginning of this year we have had 6 falls on our unit. So hopefully with our apron we can not only reduce the risk of the risks that come along with being restrained, but also reduce the instances of falls on our unit. So what exactly is this activity apron? Well, this apron is specifically made by Posey, who is the same manufacturer as our regular restraints that we use currently. It is meant to be a sensory stimulation therapeutic device that is designed for patients with decreased cognitive function. The apron's bright colors offer visual stimulation to people craving that, and it has a variety of textile materials that offer tactile stimulation. You can keep the patient's hands busy with this little lace going up and down on the left side over here. There are zippers, there are buttons. This little pocket right over here actually opens up, and there's a little plastic window inside that you can stick pictures of loved ones or family members. This little pocket over here is great if you have patients who are rolling up tissues or want to stick something in and out of there. It really offers a lot of stimulation. Over here is a little Velcro strap that they open and shut along with the zipper. This lace over here, great for fidgeting, a really nice alternative, especially for the patients who are fidgeting around with their lines and with their IVs. And yeah, it really offers a center for our patients and to fidget around like they do with all of their medical devices, except safely on this apron, hopefully distracting them from anything that we actually need them to keep on themselves. So who exactly can benefit from this activity apron? Before I get into this, I really do want to preface that while we really are trying to decrease the use of restraints on the unit with the activity apron, remember that it's always best at the end of the day to use your judgment, and if you really feel that the safety of yourself or your patient really depends on applying the restraints, then go right ahead and get that restraint order from the provider. Obviously, safety comes first. Ideally, the activity aprons will be applied to patients prior to the situation escalating to that point. So it's really as a prevention, something that we are going to use prophylactically to keep patients from getting to the point where they are ripping out, their lines and jumping out of bed all willy-nilly. So here are some guidelines to who you could potentially be giving the activity apron to. Confused and agitated patients, which we, for our data collection, have categorized as patients who have a RASS of greater than 0 and a Glasgow Coma scale of 4, 6, or less. So that middle 4 over there is confused for verbal responses. Yeah, they would once they get to that confused place, they could really probably start benefiting from some of the stimulation on the activity apron. Patients with a past medical history of dementia, if you know that you're getting a little 89-year-old lady up in room 28 at change of shift, whip out the activity apron. Past medical history of dementia, I guarantee you, she started sundowning in the PACU, and that one-to-one nurse didn't even realize it because she can have all eyes and all ears on her. She's going to come up here. She's going to be so confused. Put that activity apron on her, keep her from, pulling out her IV or yanking off her ortho splint. Keep her in the bed. It really, as a preventative measure, it can offer her tactile stimulation, visual stimulation, and kind of keep her grounded with that stimulation. Some patients who are on AWS protocol could benefit from the apron. This is really kind of more up to your judgment. Obviously, there are differences in demeanor in our AWS patients. Some of them really would benefit from the use of the activity apron, while others would probably just agitate them a little bit more. So that really is kind of up to your discretion. The main criteria that I would really like to speak about and that I will address in the next couple of slides is our patients who are suffering from delirium. We measure delirium by using a CAM-ICU score. This is something that really is not very well documented on our unit. It's not very well practiced. I don't think that many nurses on our unit know how to conduct a CAM-ICU assessment. And a lot of times we just go and say, no CAM-ICU, or just when the patient starts getting a little bit confused, we say, yes, CAM-ICU, but we're not really utilizing the appropriate assessment. So in the next couple of slides, I'd really like to go over that with you all, because the CAM-ICU, positive CAM-ICU, really is a very great indicator for whether or not our patient will benefit from this activity apron. So just a little bit about the CAM-ICU assessment. It's not just a box in Epic that we type no in at the beginning of the shift. It's actually a real assessment that aids nursing in assessing patients for delirium. The CAM-ICU assessment should be completed at the start of every shift and with changes in patient mental status. A CAM-ICU score of 5 or more indicates a positive CAM-ICU score and the presence of delirium. Right on the the left side of the screen, you can see this cool little flow chart over here. It kind of just breaks down the flow sheet for the CAM-ICU assessment. I really liked it. It was really colorful. And the next slide, I'll show you a little bit of a bigger view. Okay, so this is the bigger, brighter view of the CAM-ICU assessment flow sheet. So what you're going to do at the beginning of each and every shift, and anytime you feel that your patient is having a fluctuation in mental status, you're going to open up that CAM-ICU in Epic flow sheet, and it's actually going to walk you step by step exactly how this is laid out, and instructions will show up on the bottom right side of the Epic flow sheet screen. So the first thing that you're going to do is you're going to assess for acute changes in mental status or fluctuating mental status. If your patient is oriented, has been oriented, remained oriented overnight, and is the same as he was when you come back in the morning for your next shift, then you're going to write no, he has no acute changes, no fluctuating course of mental status, and he will be CAM-ICU negative with no delirium. However, if he is experiencing some fluctuations or an acute change in mental status, you're going to mark yes, and Epic will take you to the next step of the CAM-ICU assessment, which assesses for inattention. Like I said, instructions for this step of the CAM-ICU assessment will show up on the bottom right side of the screen in the flow sheet. So what you're going to do for this part of the assessment is have the patient hold your hand, have the patient hold both of your hands, and you're going to tell them, I'm going to tell you a series, I'm going to read you a series of letters. Every time I say the letter A, squeeze my hand. Epic has us using the save a heart combination. I find it really the easiest one to remember anyways. I don't have to read it off the chart. So you're going to say each letter pretty slowly and deliberately. Make sure you're saying it clear. And every time you say the letter A, your patient should squeeze your hand. You're going to say it slowly and deliberately like this. S, A, V, E, A, H, A, R, T. Now, the errors that they can have, they could not squeeze with A, or they could squeeze on a letter other than A. So, if they have 0 to 2 errors, they're CAM-ICU negative. They have no delirium. However, if they have greater than 2 errors, you're going to mark it how many errors that they've had, and the flow sheet will walk you to the next step, which is going to ask you about the patient's current level of consciousness. Any score, any RAS that is other than 0, the patient is automatically going to be marked with CAM-ICU positive, and you know that delirium is present. However, if the patient's RAS is 0, you're going to be moving on to the next part of the assessment, which is assessing for disorganized thinking. You're going to be asking the patient a series of questions and asking them to follow a series of commands that assess to make sure that they are actually able to think in an organized manner. Most people will be able to answer questions like, will a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2? Can you use a hammer to pound a nail? And then follow the commands that you can see down at the bottom over here. I'm pretty sure that you can do either or of these assessments in Epic. If the patient passes this with 0 to 1 errors, then CAM-ICU, they are CAM-ICU negative and there is no delirium present. However, if they get more than 1 error in this section assessing for disorganized thinking, then they are CAM-ICU positive and there is delirium present in the patient. We're going to want to treat that and keep that in mind as we are treating the patient. This little link over here at the bottom, this is a really great link to a YouTube video that really shows you how to complete the CAM-ICU assessment and offers a really good comparison and contrast to what a normal CAM-ICU, a negative CAM-ICU assessment looks like, to what a positive CAM-ICU assessment looks like. I watched it a couple times. I really feel like it enhanced my understanding on how to perform the assessment and definitely has given me the ability to better perform the assessment in my actual practice. So I would really highly recommend you take the time to take a look at this video. Yeah, just let me know what you think. So how are we going to actually apply this to practice on our unit? Well, I started going over it a little bit in prior slides, but we'll break it down over here now. Our patient, if you got a patient who meets some of the inclusion criteria of the Apron, such as AWS, they're delirious, they're confused, they have dementia, you know, with any of the measurements that we mentioned previously, such as RAS and past medical history, you're going to want to get that apron out and give it to the patient, allow the patient to use it. Remember, we're going to apply the apron prior to escalation. This is for prevention. This is so that we don't have to get to the point where we are going to want to use the restraints on the patient. I have found that the best positioning for the apron for patients in bed is actually not really tied around the waist, but more across the chest. The apron ties around the back, and you can make it into a little bow, just like any other regular old apron. And I really have found that patients find it more accessible and are more aware of it when it's tied around their torso rather than just around their waist, especially when they're in bed. Once you have the patient, once you got the apron on them, if you're in contact with any of their friends or their family, encourage them to send photos of loved ones to be placed in the apron. I really know that opening and closing that center pocket and seeing pictures that are familiar, of familiar faces, can really enhance our patient's experience and kind of calm them down and give them a sense of, they might feel less confused. It'll offer them a sense of comfort and familiarity. The next thing that you're going to want to do is record the demographics and the application info in the activity apron spreadsheet at the nurse's station. There is going to be a spreadsheet. It is not a very lengthy spreadsheet. It is not does not require too much thinking or too much application. I will go over it in a couple of slides, but it's pretty much just asking for who you applied the apron to, when they applied it to, whether or not they were given antipsychotic medications, or if restraints were applied in the end during their visit while they had the activity apron, and a few other questions like what their RAS and what their GCS was at the time that the apron was given to them. Charge nurses. Please be sure that utilization of the activity apron happens prior to restraint application. If restraint application occurs prior to trying the apron alternative, there's going to be another flow sheet, spreadsheet. It's just like a little Excel sheet that'll ask you to document the reason why the restraints were applied prior to use of the activity apron. So what are we doing with the activity apron once the patient is finished using them? For now, 2 aprons are available on the unit for use. Hopefully we are getting more in the near future, but I think 2 is okay to start off with. They are single patient use for now, but please do not throw the aprons away. We are trying to get them washed and working closely with our linen management to see if they're actually going to be able to be washed and reused from patient to patient. We will give out updated disposal instructions as soon as we know whether or not the aprons can be washed. For now, we can place a designated linen bag in the back room where we kind of keep all of our clothing, and our bags, and we can place the used aprons in that linen bag. Just let Laura or I know if there's an apron back there. We're not aware of it. We just want to make sure that we can take care of it and send it to get washed if that's the case. And we'll definitely keep you updated on what the official disposal / washing instructions are going to be, really hopefully soon in the near future. So this is what our activity apron application sheet is going to look like. I kind of filled it out in these little red words over here, just so that you can get an idea of what you're going to be looking at and the information that you're going to be filling out when you apply the activity apron. So right over here in this first column, you can see we're looking at the date, the patient, and the room that the apron was applied. So right over here, we got 3/9/2021. Mr. P. Brown in room 34 had the apron applied. Why was the apron applied? Now this could be a number of reasons. I picked to say that my patient was sundowning, which really, I think probably it was a little bit on the late side. But if your patient has a past medical history of dementia, like I said, just get it out before they even start sundown and give it to them when you're getting them ready for bed. But anyways, Mr. P. Brown, he started sundowning. So we gave him the Apron. Right over here in these diagnoses, we're asking, does the patient have a TBI? Do they have a history of dementia? Are they on AWS protocol? What's their CAM-ICU score? What's their GCS? And what is their RAS? So Mr. P. Brown, as you can see, yes, he has a past medical history of dementia. He is CAM-ICU positive, and his GCS is 446. He is, getting a little fidgety, picking at some stuff, so his RAS is a +1. We're going to put the Apron on him. Hopefully it'll distract him from pulling anything out that we want on him, and keep him in bed. Now, over here, this section over here is for later use when restraints, if restraints are applied in the end. So, are restraints applied? 2 nights later, Mr. P. Brown he is not, well, 1 night later, he is just not having it. He yanked out his IV, he's pulling out his NG tube. We can't, his core pack was bridled and he ripped that bridle right out. That's pretty powerful and painful. So he also ripped out his Foley with an inflated balloon. Really wild stuff, man. So yes, restraints were applied. We decided to go with a little bit of a less invasive restraint. We are going to give him bilateral upper extremity mitts. And then the next night he, wowed out even more. He needed just some Halidol to get him to go take a little nappy nap. So he got 1-time dose of Halidol 1 time. So this over here, you're going to record the pharmacological agent that you use and the date. And over here, you're just gonna really just a tally mark is fine. However many times an antipsychotic was used with this patient. That's all we're asking over here. We do ask that even if the patient is put in restraints, keep that activity apron on and nearby, especially if they're just in mitts. They can still, play around with it. And who knows, when they're ready to come out of the restraints, you might want to just put that apron back on them, see if that, enhances their experience or decreases their need to fidget around with stuff that they shouldn't be touching. So like I said earlier, the activity apron really is meant to reduce the need to apply restraints, but in some cases, restraints are just what are needed for patient safety. Obviously, there are going to be some situations where you just can't start with the apron. So all that we ask is that if you're ever in a situation like that, you fill out, or the charge nurse can fill out this little log over here, which will be with the activity apron application log in the same place on a clipboard at the nurse's station. And if you can just fill out the, oh my goodness, I'm sorry, I'm yawning, but if you could just fill out the date, the patient, and the room, what type of restraints were applied, and then the reason for applying the restraints without the apron. So as you can see on 3/9/21, bilateral wrists were applied to one of our patients before an apron was applied because the patient was attempting to rip out their new trach and was completely confused and disoriented. So in a case like that, where it really is a matter of unsafe patient behavior right away, you're obviously going to kind of skip that apron and go to what is safest for the patient. And that concludes our unit-based education for our activity apron initiative. If you have any questions at all, any concerns, anything, direct them to Laura or myself. We will be more than happy to assist you, help you out with anything. And yeah, thank you all so very much for your teamwork and your collaborative effort in making this process improvement initiative possible. We really, really, really could not do this without you. You are all rock stars, and we love you so much, each and every one of you.